Hey guys, Mike with FlightBridgeED. I've been an EMS training officer since 2008, and I don't know how many times I've had to deliver the bad news to someone about an expired certification. That means no work. That's where Piace comes in to save the day. Never be caught off guard again with an expired cert. Go to the App Store for your device and search for Piace, P-I-A-C-E-T, the one-stop application to manage and share all of your certifications. You know you don't want to be that guy or gal, and don't rely on your agency to tell you about your certifications. Go to Piace to manage your own certs and have some peace of mind. Download Piace today.
The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today's podcast is going to be an update on the Surviving Sepsis Campaign Bundle, and so this will be the 2018 update. I will put this in the show notes, so again, you can find this on the website underneath the podcast in show notes. And this is just going to be a synopsis on this paper. I'll give you my thoughts, and again, I always say, research this stuff for yourself. Take this stuff to your medical director. Ask and research, and I think you're going to find the things that I put out here. I will always share my sources, and there's some things about this overall update that I kind of question, and I think if you talk to different physicians, the top critical care docs around the world, a lot of them don't put a lot of weight into the overall Surviving Sepsis bundle, with some of the overall treatments. I think some of this stuff is good, some of the stuff I question, and I'll hit on that stuff. So the biggest part of this is the Hour 1 bundle. That's the biggest change that you're going to see, the Hour 1 bundle. Whereas, the past, you had the 3-hour bundle and the 6-hour bundle. Now they're saying it's all about a single 1-hour bundle, and it's all about our intentions to start resuscitation immediately in that first hour. Now, this is based on what's called time zero. Time zero is truly a reflection of time of presentation, whether that's in an ED or if you're in an outlying area, right, an austere environment like pre-hospital EMS or HIMSS, you have to figure out where that time zero starts. And it's all about then going through those steps to identify these candidates. We know we can use the pre-hospital model called the QSOFA, and that is essentially looking at a patient and saying, all right, are their respiratory rate, is that greater than 22? Systolic less than 100? Altered mentation. I think that we have to look at that, though, and be very objective, because we have patients that definitely will have a rate greater than 22. Patients definitely have systolics less than 100. To me, why are we targeting a systolic? We should be targeting a MAP. But how can you add to that? Well, a couple ways to add to that is you can actually check lactates. And for example, Mike Fricest, training officer for Clackamas County Fire District 1 in the Portland metropolitan area, right outside of Portland, and they actually have lactate monitors, and so they're doing lactate finger sticks in the field. If these patients are falling under the criteria of the QSOFA guideline, then they do a finger stick. They identify what that lactate is. If that lactate is greater than 4, another step that they take is they actually place end-tidal CO2 waveform capnography on these patients based on nasal cannula application. If that end-tidal is less than 25, then that patient falls under a high probability of having that sepsis. And so that's where that time zero starts. They do a sepsis alert, and they get them to that appropriate facility. You look at a program like the ground EMS side in Greenville, South Carolina. Very, very impressive. They actually do the same things. They actually start empiric antibiotics, broad spectrum. They'll draw cultures prior to giving those antibiotics in the field. So they already have broad spectrum antibiotics established in the field before they ever get to the hospital. So that's taking it a step further. And I think that that is the key, and that is, improving overall survival. Now, how do we look at these different tests? As far as lactate goes, I'll explain my thoughts on lactate and what lactate truly is a reflection of. But what this update is saying is measure lactate initially. If that lactate is greater than 2 millimoles per liter, then recheck that lactate. I think the standard thought process is if we have a lactate greater than 2, let's say it's 4, you establish that this patient probably is a candidate, that they're probably septic, you get them into the system. You start resuscitation, whether that's fluids, whether you're going vasopressors. We'll talk about what decisions go into making that assumption. Once you establish that, at that 1 hour mark, if you recheck lactate and that lactate is still now greater than 2, that's where you have, a stress response. And that's where lactate is looked at as specifically that stress response. Now, when we look at lactate and we directly think about lactate we know is not an indication of tissue hypoxia. Lactate is specifically an indication of glycolysis. Whether you're in aerobic or anaerobic glycolysis, your body builds lactate in that process, and our body utilizes that as a biofuel. Our brain and our heart utilizes lactate consistently every single second. We need that to stay alive. So you think about this. If our patient is in that hyperdynamic response that you see in that early sepsis, they're going to have more beta 1, more beta 2 receptors that are being fired. Our glycolysis starts by beta 2 receptor activation, skeletal muscle, our lungs, bronchodilation, our liver. So our liver gets that message, beta 2 receptor stimulation, and so that's what triggers glycogen release, and it starts the whole glycolysis, Krebs cycle, oxidative phosphorylation process. Lactate is a byproduct of that. Whether you're in aerobic or anaerobic metabolism or respiration, you're going to build lactate. So the higher our sympathetic response is, the more lactate production you have. And that's where lactate is looked at. Lactate is specifically looked at as a indication of stress. If you have excess stimulation, that beta adrenergic overall stimulation, then you're going to have more lactate production. Now, whether higher lactates truly reflect a worse outcome, I think that the thought on that is varying. It used to be that any lactate greater than 2, once you've started resuscitation, is considered a 10% increase in mortality. Now, whether that is the case or not, I can't answer that. I can tell you, though, that some of the treatments that we give, if you start an epidrip on somebody, you're going to absolutely have more lactate production. So even looking at lactate clearance, the way we looked at it a few years ago, is kind of skewed, because if you're giving treatments that actually stimulate more glycogen release, glycolysis, then you're going to have more lactate production. That's just a part of that. Like, you can't have glycolysis without lactate production. So I don't know the answer to that. I think you still have to, go by and utilize lactate, but you have to really consider what you're using it for. Obviously, it would make sense if you're lowering the patient's stress response, if their disease process maybe is getting better, that hyperdynamic response is now lowering, your lactate production should slow, and that's showing that they're getting better and there's improvement. And I think that's that initial thought, utilizing lactate. A much better marker in sepsis as far as a lab is called procalcitonin. Procalcitonin is very, very specific for bacterial involvement. If that number is greater than 2, we normally don't have any type of procalcitonin levels in our body unless you have any mild inflammatory disease. You're not going to have any procalcitonin. So a marker greater than 2 is an indication of that bacterial septicemia as a possible cause. So let's go back up to our, guidelines. The next thing it says is obtain cultures before you start those antibiotics. As I said, Greenville, South Carolina, that EMS system has been doing this actually for years. This is not a new thing for them. They're very, very ahead of the game in a lot of areas. I was very blown away by what they were doing. So, kudos to them. Once you get those cultures, remember cultures need to be drawn in 2 specific sites. They can't be off the same site. It has to be 2 separate sites. You're going to give those antibiotics, broad spectrum again, gram negative, gram positive. And then their number 4 guideline is begin rapid administration of 30 mils per kilo crystalloids for hypotension or lactate greater than 4. Here's where I have the big problem is this. This right here, this is what's killing our patients. We cannot be doing this. I am not going to get on the soapbox, but this is what blows my mind is that this statement is still in these guidelines. We know that crystalloids, specifically normal saline, think about it's called iatrogenic saltwater drowning. If you look at Stewart's model, acid-base model, it really, really shows the differences between normal saline and a balanced solution like LR. We're going to do a specific podcast on Stewart's model and compare that with, other ways to identify acid-base balance. And I might team up with Tyler Christofoli on that. But when we look at fluid, number 1, here's the thing, is the way we should be giving fluid, number 1, is based on be definitive in why you're doing it. If you've taken our review courses, I've been really hounding this and teaching this for the last 3 or 4 months. And what we need to utilize is, again, utilize your end-tidal CO2 waveform capnography. Use the concepts of what's called passive leg raising. And this is something that Dr. Paul Merrick teaches. It really does work. There's, programs, there's hospitals around the country that are utilizing this, and, we only need to give fluid if they need fluid. So the way this works is you put your end-tidal CO2 on this patient. Let's say this end-tidal CO2, and let's use Mike Burkess program in Portland, Oregon, right? Their fire crews have a patient that falls under the QSOFA guidelines, has, 2 out of the 3, has a lactate greater than 4. They put end-tidal CO2 on. The end-tidal CO2 is 25. Now, here's the problem. Let's say they go off of this standard canned language of 30 mils per kilo crystalloids. And so they give this patient is maybe obese. Maybe this patient is 250 kilos. There's patients out there like this. Do you give 250 kilo patient 30 mils per kilo? Think about that amount of volume. Or do you look at that, number 1, from the ideal body weight perspective? We need to be looking at it from the ideal body weight side, not based on, their true weight. And so this is considered what's called adjusted body weight based on their actual size. And I was actually talking about this with Tyler Christofoli the other day. Do people that are obese, do they have more capillary filling? I don't know. I know fat and lipids are what's called hydrophobic. They don't like water, so they're not going to be holding water. And I just really doubt that if I, at 5'11", if I weighed 400 pounds, it doesn't mean I need that much more fluid volume based on that size. It's kind of the same concept as think about tidal volumes. If I weighed 400 pounds, are we going to use a tidal volume based on a 220 kilo person? And that's the answer to that is no. My lungs have not gotten bigger. So I think the key here is use end-tidal CO2 as your gauge. And so coming back to our fire crew, they have that end-tidal CO2 of less than 25. And instead of dumping all that fluid in this patient, what they need to do is they need to do passive leg raising. So here's how it works. You have your patient sitting up. They're semi-Fowler, 30 degrees head elevated. You identify what your end-tidal is. Let's say it's 24, 25. Your blood pressure is 80 systolic. All you have to simply do is lay your patient down flat, lift their legs, right? Lift their legs up, and watch what your end-tidal does. And what you'll see is you'll see that end-tidal climb. So let's say that end-tidal climbs to 36, over 1 to 2 minutes. What does that tell you? That tells you that they are volume responsive. They actually need fluid. Now, they need fluid, but that doesn't mean they need 30 mils per kilo. They need enough fluid to make a change. So what have you done by doing passive leg raising? Well, we have to remember 15 to 20% of our overall blood volume is in our legs. Our legs hold a lot of volume. So all you just did is you did a fluid challenge. You pushed all that volume into the core, and you got that corresponding change in your end-tidal CO2, because we know end-tidal CO2 is a direct reflection of perfusion. Now we give volume. And what I would recommend is you just give 500 mil fluid challenges. Don't dump 30 mils per kilo in somebody. Give 500 mils and assess your patient. Because the more volume we give, the more secondary problems that we may or may not see. Obviously, if we go back to our older sepsis guidelines, our older bundles, and there's no reference in this paper of CVP, but I hear this constantly, still hear this constantly about targeting a CVP of 8 to 12 for a normal patient in sepsis, or 12 to 15 in a patient that has longer standing hypertension. And the thought process is wrong. We can't be targeting a CVP. And Tyler Christofoli from the Foam Podcast illustrated this perfectly when he came on as a guest host and did the podcast on CVP. So if you haven't heard that, please listen to that, because I think he illustrated that very, very well. If we try to raise our CVP, what happens? A high CVP is very bad, number one. We actually decrease venous return and cardiac output by increasing our CVP. Our high CVP patients actually will have a decrease in organ perfusion. They have a decrease in what's called microcirculatory flow. And high CVP patients result in, think about what happens if we have overstretch of that right atrium, those ventricles. You have a BNP increase. That increases tissue edema, so we start third spacing that fluid. It damages what's called the endothelial glycocalyx. That's the little hair-like projections that surround your capillaries and your alveoli. And it actually decreases lymphatic drainage. So I think the key thing is we have to know a normal CVP is 0. Even though the tests, the FPC, the CFRN, the CCP-C, we teach 2 to 6. It's hard for me to teach that, but I know that that's what the tests are asking you, and that's what the textbooks are saying, 2 to 6. And that, we have to understand, is just a textbook target. That is not truly what you're going to see every single patient at. So I say all this because we have to be very careful with giving volume. Now let's go back to this fire crew. Let's say they do passive leg raising, and they have that end-tidal of 24 to 25, and they do exactly the same thing. Patient is sitting head elevated 30, 35 degrees. They switch, they layer down, they lift the legs up, and nothing happens. End-tidal CO2 remains the same. What that means is that the patient is not volume responsive. Now, to add to this, let's say they're using point-of-care ultrasound, right? If you haven't been involved in the foam ed community, you may or may not have been able to look at EMS POCUS or point-of-care ultrasound, but there's a thought process of using the IVC. Do you have IVC claps? I think using end-tidal CO2 though is very, very simple. I'm not saying that using the IVC claps theory is right or wrong. I'm just saying, right now, until we have more and more EMS agencies out there that actually have point-of-care ultrasound, that is something that is going to take time to grow. And I think it's a phenomenal tool, but I think we can learn a lot simply by using that end-tidal CO2 and passive leg raising. So what should this fire crew do? At this point, what they should do is not give a drop of fluid. It means that they're not volume responsive. You just lifted the legs and gave a big fluid challenge and nothing happened. So here's the key: is they need a vasopressor, an early vasopressor, and that vasopressor is not dopamine. That vasopressor should be Levophed, 100% all the time. Levophed as that first vasopressor, and we're going to try to target a MAP of 65 or greater. We know that means that we're perfusing our brain, our liver, and our kidneys, and obviously our other core areas. So we got to come back to, that fluid needs to be definitive. And then what fluid do we go with? The fluid that we should be going with, guys, is LR, not normal saline. LR should be the one you grab most often. There are certain patients, DKA patient, that will respond well, that needs the actual, electrolytes, that normal saline, sodium and chloride content. But most patients need a balanced solution. That balanced solution that we carry is LR. So you really should be grabbing LR first, really in 99% of your patients. And when we look at LR, we have to also understand the way things break down. And there's some myths about LR. And I'll probably do a specific separate podcast on this. But, LR is a balanced solution. And if we think about what we're giving a sodium and a chloride content that are very, very similar to what our body has. But think about what the lactate does. The lactate is sodium lactate. It's not the same lactate that we actually think causes lactic acidosis, which is called D-lactate. It is sodium lactate, so it is not going to increase acidosis. But the lactate actually breaks down, and when it breaks down and metabolizes in our body, it generates bicarb. So there's an alkalizing aspect to lactated ringers that we have to remember. And you actually consume hydrogen ions. So the more hydrogen ions we consume, when that lactate gains hydrogen ions, it forms bicarb, then we actually have, the opposite. And so, number one, we're solving two problems. We're giving a balanced solution. We're not inducing this huge hyperchloremic state like you see with multiple liters of normal saline. And you have a fluid that has components that add more base, which consumes acid. And so, to me, that makes a lot of sense. So I definitely would be grabbing LR over anything. And that is the key. So, we touched on the lactate, we touched on the blood cultures before we give antibiotics. If you're in a system that they're doing antibiotics, then, I think that's great. Remember the fluid side. The fluid side needs to be definitive. That's the number one killer. Whether we're talking about trauma, burns, the secondary problems that we see with over volume resuscitation are horrifying. And it comes back to, number one, that iatrogenic injury of just dumping volume in. And think about, if we go back to trauma, we go back to, when I first became a paramedic, it was all about in trauma, get that blood pressure up to 120 over 80. You wanted to get a normal blood pressure. So, we'd give all this volume and we would essentially have a patient that was still hemorrhaging and it would be coming out almost clear. And it's all about thinking about some of the most simple progressions that we've seen in medicine have been do less. Maintain a map that is minimal for perfusion. When I did the podcast with Dr. Morris with Grady Memorial on Reboa, one of the things that was very profound that he said to me was that in penetrating trauma without a traumatic brain injury, they actually will target a map of 50 to 55 in those patients, not 65. And it's because, they're trying to limit the bleeding. And so I think we have to remember that sometimes less is better. And just because we've done that way all the time, or, in the past 30 years, doesn't mean it's right. The more evidence that comes out, the more studies that we can look at and evaluate, the more information that we have to, maybe change our practice. One of the things that they have on this paper, this update, is page 2, they have table 1 that says bundle elements with strength of recommendations. So they have measured lactate levels, remeasured if initial lactate greater than 2. It says weak recommendation, low quality of evidence. So I want you to just kind of remember some of these. Obtain blood cultures prior to administration of antibiotics. I think that's a best practice statement is what they're saying. Administer broad spectrum antibiotics, strong recommendation, moderate quality of evidence. Rapidly administer 30 mils per kilo of crystalloids for hypotension or a lactate greater than 4 millimoles per liter. Strong recommendation, low quality of evidence. So, is this just opinion? And that's where I struggle with this update is why is it even in there? If there's no quality of evidence, why is it in here? And you go down to the area that they discuss this on page 3. It's the first section on page 3. And I think the statement that really got me was, although little literature includes controlled data to support this volume, recent interventional studies have described this as usual practice in the early stages of resuscitation and observational evidence is supportive. Like, I don't understand that. I don't get it. Usual practice. Well, just because it's usual practice doesn't mean it's correct. I think the thing that is correct, though, is early vasopressors. Be definitive in your fluid, management. And I'll leave you with this. If you haven't taken any burn classes lately, go to your local burn center. Ask them what they're doing with fluid resuscitation. And I think what you're going to find is that we have the consensus formula, we have the Parkland formula, but even Parkland Hospital in Dallas, they don't use the Parkland formula anymore. All burn centers now are looking specifically at 500 mils per hour. That is what they want you to give, 500 mils per hour on that initial resuscitation. And then they gauge the fluid based on urine output. After that first hour, if that urine output is between that 30 and 50 mils per hour, where it should be, then they're golden. Then they maintain that fluid at 500 mils per hour. If that fluid is, or if I should say, if that urine output is less than 30 to 50 mils per hour at that point, what they do, they increase that fluid by 20%. They reassess urine output an hour later. And so they're constantly increasing and decreasing that overall volume based specifically on urine output, and that is how they're targeting fluid resuscitation and burns. And it should be no different in anything else we do. The more volume we give, the more problems we have down the road. So that's all I have for this podcast, guys. I will put this in the show notes. I want to thank Mike Verkes for sharing this with me, and I really hope that you can look at some of these concepts I talked about. If you have any questions, please email me at eric.bauer@FlightBridgeED.com. I will be more than happy to guide you to a resource if you need it. And until next time, I will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.